Welcome to the latest presentation of the National Telehealth Resource Center's webinar series. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. These webinars are presented on the third Thursday of every month. So if you could advance there, Natalina. So located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers. Each serve as a focal point for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Next slide, please. Before we get started, just a couple tips. We have muted your audio. You can use the Q&A function of the Zoom platform for asking your questions. We will answer and address questions at the end of the webinar. The webinar is being recorded today, and you'll be able to access the webinar and past webinars on the National TRC YouTube channel. Our webinar today is sponsored by the Southeastern Telehealth Resource Center. My name is Lloyd Sermons. I'm the director of the Southeastern Telehealth Resource Center. We appreciate you being here, being a part of our webinar today. I've invited Ms. Natalina Zisa with Nemours to share with us today. And so you can see here the title is Nemours, Anytime, Anywhere. Next slide. So you can see just some objectives here. We're going to look at the overview of Nemours Children's Healthcare System and its telehealth program. Natalina is going to talk about Nemours telehealth integration into operations, as well as its emphasis on patient experience, and then share some strategies used in a state where getting a telemedicine program up and going in a state where there's no parity law, no reimbursement. So Natalina, with that, I will turn it over to you.
Thank you so much, Lloyd, and thank you everybody for your time and for having me today. Again, I'm Natalina Zisa, Telemedicine Operations of Nemours Children's Health System. I've been with Nemours now for 5 years, and I'm super excited about this opportunity to share some of what we have been working on. So we'll jump right into a little bit about who we are and what we do. So Nemours is a non-for-profit health system dedicated to pediatric healthcare. We have 2 freestanding hospitals, one in Orlando, Florida, and one in Wilmington in Delaware. In addition, we do have more than 80 satellite locations that includes primary care offices, urgent cares, and specialty cares. So you can see some numbers here that just highlights some of our statistics. So that was technically where we are, but who we are. We're driven by our Nemours True North. And what that means to us, it's like a compass that drives us towards our aspirational goals. And if you look at the goals here that we have defined for ourselves, for instance, no delays in delivery, 0 defects, perfect care. And you're going to ask yourself, like, this is not something that really can be achieved. And that's why they're aspirational goals. However, if you look at the other side of it, if there was just one child, if it was one, like that one child is your child, and we had a defect, we did not provide the perfect care that you expected, that one child is actually too many children in that case. And we're driven by our legacy. Mr. Alfred I. DuPont, his legacy, which he started with gunpowder to begin with, and this is our founder. His legacy was to remove human suffering, and what better way to start from the ground up, which is starting with children. So as a source, a trusted source to our families, to our children, to our community, to our partners, we want to be that ideal source where we can empower, whether it's community physicians, and empower our families to own and take care of our children, our community children, and help them develop to be great independent members of our community. And what better way to do that via just being that, giving them that availability, being anywhere, anytime, being available to them. And this is the concept where Nemours anytime, anywhere came from. How are we doing that? And or how did we start doing that? So we looked internally to begin with. If we want to be that one trusted source, that unified voice. So we looked internally and we started seeing that we had different departments, different strategies happening. However, they're working independently. And you'll see those, I'll go into detail about that. But what we decided to do is bring those together. Instead of, for instance, our Reading Bright Start program having a niche of schools that they're working with, and Nemours Care Connect, our telehealth program, going to different schools, for instance, and pitching that. Now we're bringing all of those digital strategies together internally and going out as one voice, so that when we do contact a parent, when we do come in contact with a child, a school, a community member, a PCP, we have that, we're bringing everything to the table. We're making that streamlined experience to all. And this is giving us that maybe access to expand our Nemours brand and establish commodity in our communities. So these are the different strategies that I just mentioned. So I'll go through them just briefly so you understand what I'm talking about. My Nemours is our parent portal, where parents can go in, schedule appointments, for instance, look at their children's records, whether that's vaccinations, whether that's labs, whether that's after visit summaries, discharge summaries. So that's our parent portal. It's a digital asset that we have where parents can access this information remotely. Nemours Link is a kind of similar to a parent portal. However, it's a community portal where, for instance, separate health systems or schools can start, when we're working in conjunction together on the same patient, we're sharing a patient in that instance, they can start accessing the medical record, our notes that our doctors are providing into our electronic medical record. They can access that so that to complete that continuity of care. And we're all working together, even though we might be looked at as different entities, we're working together towards that same goal, which is making that child healthier. Reading Bright Start is one of our digital assets, which focuses on early literacy for children up till the age of 5. Focusing on how early literacy has a huge component in defining a child's or an adult's health, and making sure that we're screening early and being proactive in all the needs necessary that might trigger a better outcome. Kids Health has Kids Health for parents, and then Kids Health in the classroom. This is a portal that's accessible nationwide. And I'll show you some statistics. I think there's more than 260 million clicks a day or something like that, where it shares health information, and it's tailored, for instance, if you can see, for parents, for kids, for teens, and for educators. So it tailors it specifically to the audience needed. And that way, for instance, as a mom, I can go in and say, my child has a rash, and I can look up rash, and it gives me symptoms, it gives me signs to look out for, it gives me maybe some home remedies, it gives me solutions and whatnot. So I can use the same piece and put it for a child, so that if my child is 8 years of age and needs to learn how to cope with his asthma, I can also print out that material, but it's more tailored to his level of thinking. And that way he can also be part of managing his own health. Same for educators. There's full curricula that is tailored towards a grade level that talks about health. It goes everywhere from your washing your hands to sex education to, for instance, diseases that might be communicated. So it has the different grade level curricula that educators can participate. They can print out with worksheets and whatnot and teach in schools. And finally, we have our Care Connect platform, which is our telemedicine platform, available for members of our community within the 6 states that we are in. So any child within those states can access it. And the Care Connect platform is both on demand and scheduled, and we'll discuss that further in details. However, these are the different digital assets that we have, where we're merging them all together to have that one unified experience. So just some statistics on Kids Health, for instance, 260 million visits annually to kidshealth.org, and it just gives you some ideas of, these are material, like a snippet of the material that we attach to our after visit summaries, whether that's discharge instructions or after visit summary for specialty and for urgent cares, where we're educating the families to be able to take control of that illness, for instance, and better support their child through this material. A little bit about reading. Bright Start, which I touched on, which is the program that focuses on early literacy. We also have prevention and population health programs focusing on asthma management, child obesity, and more. So moving into what we're here to talk about, it's more about the telemedicine program. So our Telemedicine Care Connect program is a multi-use telehealth platform. So if you think about it, it's an overall branching umbrella that encompasses different service lines per se. So you have your clinician to partner facility, you have your clinician to family, 24/7 on demand, store and forward. Some use cases, just to give you examples of what we're doing, we have healthcare facilities, for instance, that are non-Nemours that we partner with within our local communities, miles away from our hospital. If a child if a family chooses to go to that local hospital that's not Nemours, we have those associations and relationships with that hospital. Shall they need pediatric care, specialty, whether that's PICU, NICU, specialists like endocrinologists, we use telemedicine to connect with them and be that, whether it's a consult or become that child's pediatrician via using technology. So that's one example. We're on cruise ships as well. Another example is, for instance, within primary care offices, we're bringing in specialty like behavioral nutrition into primary care physician offices via telemedicine. So if you think about it also, let's just take the Panhandle, for instance. It doesn't have a lot of specialties around. We can capitalize on physical locations that we have, or physical locations like community PCPs that we partner with, put a telemedicine cart in there and bring specialists to that child in need, versus, if you turn the picture around where they're having, if they really want to see a Nemours specialist, they're going to have to drive, 6 hours to for instance, our local hospital, or maybe 3 hours to another location. So it just gives you an idea of what we're trying to do, leveraging the telemedicine platform to expand coverage to children in need throughout the states that we're in. Store and forward, I'm sure everybody here is savvy, with the concept. However, we have a maternal fetal medicine program, telemedicine program. We have the radiology second read opinion program. So we're doing different things in that aspect, in that service line as well. 24/7 on demand is one of my favorites, and because I work heavily with the whole group. So what differentiates Nemours with their 24/7 on-demand urgent care program is that we employ our own physicians. So they're all pediatricians, and we have them cross-licensed in 6 states now, going into 7. We have built-in real-time eligibility with payers to include both Medicaid payers and private payers throughout the different states, including states like Florida that we don't have parity or reimbursement. We're working really heavily because we went out into our community and listened to our PCPs. And what we found is it's extremely important to highlight and showcase that continuity of care to our physicians, to our community physicians that we're partnered with, and to the patient and family. So in that instance, we ask within our platform for the PCP, who is your PCP? Even though we're documenting into our electronic medical record, we might have access to that. But for the new patients that we're seeing, we ask for it up front so that we can connect with that PCP and say, we send them the after visit or the progress notes and say we connected with your patient. If we do have record of a patient that we've seen 6 times, for instance, in our emergency departments, we do start educating that parent, saying, okay, we've seen you 6 times in our ED and you've used telemedicine 3 times. It's really important that you connect with your primary care physician. Little Johnny, for instance, is due for his vaccinations or whatnot, or his well child visit. So we're working very hard to complete that circle of care and bring the child back to their medical home. I touched a little bit on the educational material through Kids Health that we do with parents. Every child that we see via telemedicine gets, and their parent gets, Kids Health material, and we go over it through that visit so that they understand what the problem is and how they can be a crucial part of the solution in caring for that child. School-based telemedicine, I'll touch a little bit further on that, but we're using this group, the 24/7 on-demand group, physicians to support our school-based telemedicine in the state of Florida. We have a discharge follow-up visit program, and this is to reduce the admissions to our EDs and readmissions to our hospital. So what we do with every child that's discharged from our hospital, we provide a free visit that's tied into that global fee of the encounter. And that way it gives the parents and the patients the opportunity to connect for any questions, whether that's allergies to medication, because we see that a lot after a discharge, or they're really not sure how to care for an incision, or even following up on an incision, let's say if it was a wound or something like that, rashes, or even the progression of the disease that we see. When they come into the ED, they might have certain symptoms, but as the disease progresses, they might have different symptoms that are alarming. All these tie into the factors of why we see a lot of readmissions and returns to our emergency departments and hospitals. And our discharge program has been very successful in cutting the numbers in half that could have, would have or could have returned to our ED. And you can see 64% of our visits, we've avoided an urgent care or an ED visit or an emergency department visit. And we've had a high number of satisfaction throughout. Moving into the schools, so it's the same 7 physicians. We have 7 physicians that populate our 24/7 on-demand urgent care. And these are the same physicians that also are available to our schools that we're partnered with. And the idea of school-based is also touching on access. We've realized that within our hospital setting, we're surrounded by schools and community children that sometimes either don't utilize their PCPs or we're seeing a heavy utilization of our EDs. So being able to extend that access, where we found mostly the barriers to that high utilization is because lower income families not having the time for the parents to leave their jobs and take their children to school. We've noticed sometimes through talking to our school partners that there's a high absenteeism, not only for the child sometimes, but also their siblings. So for instance, if a child has an older brother, mom and dad can't afford to take time off of work. So they would take out the older child to sit at home. So just understanding the barriers that our community has and understanding those access barriers being in schools helped facilitate, at least bridge that gap that we're seeing. And what our program looks like, you can see some pictures here, is that we have a cart with a Surface Pro, and it has peripheral devices to include an otoscope, a stethoscope, a derm cam, and we utilize this via whether it's a nurse or a health aide at the school that helps triage the child and helps assist with the visit so that our physicians can get the most out of the experience and also can provide a higher level of care than otherwise that the child would have gotten. And in this instance, some of them we've not contracted, but we've associated with pharmacies, local pharmacies around those school systems where we could prescribe medication to that pharmacy. Depending on the arrangement, they might be able to deliver it to the school. And then medication, so the child would have seen a physician, medication would either have been started or at least prescribed by the time the parent or the guardian has left their job if they needed to pick up the child. So we've seen how much time it saves, how much it's time, and sometimes it's healthcare otherwise not happening, really, because a lot of our parents stated after like surveying them, they would not have taken the child. They would have let them write it out per se at home. So just being able to provide such care to our communities has been such a blessing, and we have parents sharing their experiences. Me personally, I've spoken to a parent that her child has seizures, and she said every time her child seizes, she had I guess a flexibility to work from home. But what she did, she wanted her child to continue going to school and have that the quality of life she wanted for him. So she would go and sit in the school parking lot for the next 2 days, just hoping he doesn't seize again. And our school-based telemedicine program being put in that school where the child is, she expressed how grateful she was, where she has that peace of mind to actually leave that parking lot and not have to just hover there for a couple of days. Meanwhile, she's fearful that her child is going to have another seizure and she's not going to be able to access him. This time she's able, for instance, to connect along with the doctor. So we have an invite option where we can invite the parent into the visit and she can be part of it. So it's just overall, just an explanation of the different features we have in our school-based telemedicine program and what they're utilized for. So just to touch a little bit on what we're doing. So whether it's school-based or whether it's 24/7 on demand or specialty within our telehealth, because one of our states is the state of Florida, and we know there's no parity in reimbursement. So that's a huge barrier. Barrier from engagement with patients, like patients don't want to pay out of pocket for it. Barrier with engaging physicians. Physicians don't want to provide services if there's no reimbursement. So there's a lot of barriers when it comes to the state of Florida telemedicine, lack of parity, lack of reimbursement. But we've gotten some, creative ways to at least make things work. Obviously, you have your fee-for-service model, right? Whether it's specialty or the on-demand service, there's a fee-for-service model where you can pay, for instance, a flat fee of $60 or something and access a physician. With schools, we've seen grants and donations where someone would come and say, implement telemedicine in this school, and they would pay for this many visits a month or maybe across the board for the entire year. So we've been very blessed to have donors that are really investing in these initiatives. Just how we did with our discharge program within our emergency departments and also with our post-op visits, trying to utilize telemedicine within those I guess, areas where we can incorporate it as part of the global fee. So for instance, as part of the global discharge or inpatient or ED visit or surgery, we start providing follow-up visits to that patient. so that we can better serve them. It's a more convenient way. For instance, if it's just an incision that someone needs to see before they remove the stitches, we can do that. There's no infection. So trying to utilize telemedicine, getting patients engaged, used to it, getting physicians utilizing it, we're taking away that burden of reimbursement. It's just moving in the right direction, because once they start utilizing it, getting used to it, liking it, it would drive them more to become more creative in ways to actually utilize it further. We've also worked heavily with our commercial and Medicaid payers, where we have existing relationships and capitalizing on that, highlighting the benefit via some pilot programs that we're doing, for instance, our discharge program, and showing data and proof how, for instance, telemedicine can impact a child or can save our healthcare system, or can have a better quality of life. So having those pilot programs, working with our Medicaid and commercial payers, and having that agreement that, yes, we will start providing telemedicine services at, for instance, for Medicaid patients at zero out of pocket, and you would reimburse for this, and highlighting those different programs that are important to them, for instance, the ED for Medicaid, or for instance, some specialty for commercial payers. So working with them to have that agreement for reimbursement. So that's one way we've gone over the whole non-reimbursement state law. Partnership with other health systems, for instance. So as I mentioned before, it's kind of like a fee for service, but from partner to partner, where we can become a consultative PED to another health system, shall they need us. And then it would be a flat fee, whether they see a NICU, like an intensivist, or whether they see a specialist. So we work out those agreements with different health systems so that we can start communicating via telemedicine and reaching those children that otherwise won't have access to us. We're heavily involved with our government relations, both on the state and federal levels, to maintain those discussions about legislation and parity and reimbursement in the states that don't otherwise have it. With our focus on the awareness and education that we do both internally with our PCPs or with our specialists, having them engage in telemedicine pilots, having them trial things out, or for instance, with our marketing strategy with our communities, asking folks to download the app and try it out with meet and greet, for instance, meet and greet a physician. We've seen things like Christmas, we've utilized telemedicine for Santa Claus, for instance. So it's just ways to engage people and get them to utilize the service where the cost is not a barrier factor in that instance. And once they engage and try it out, they're more open and apt to use it again. So just working on those behavioral strategies. I have something here that says patience, flexibility, creativity, and even more patience. So yes, things don't happen in a blink of an eye. You have good days, you have bad days. Things take a very long time sometimes, but then you have that one champion or one child that you've saved a life, for instance, and it makes it really all worth it. So it's just having that patience to keep pushing forward. You're going to have a lot of roadblocks. And what we say internally, if someone says no, it's just no now, and it's just it's no, it's not a no, it's just not yet. And we keep pushing. We keep just trying to have more creative ways to engage physicians and parents in telemedicine. And we have also I would say it's a benefit that we're a multi-state program. So for instance, given the fact that we're in Delaware, where there is parity, where there is reimbursement, learning different strategies, seeing what's working, what's the best practices, and capitalizing on that and trying to, take it to other states. So overall, I believe just looking around, at least in the state of Florida, we are very far along in the telemedicine world, and we continue to push. And this takes me to the next slide. So pilots, concepts, near futures. For instance, we're working with Tidal Care. I'm sure a lot of you have heard of Tidal Care, but Tidal Care, bringing it into parents' homes. For instance, we're utilizing it with our asthma pilots, or bringing it into schools where, for instance, some schools don't even have a nurse. So having someone that's a little, maybe not comfortable using an otoscope or something, being able to use something a little bit more handheld and structured to your everyday consumer, using wearables and devices that can track and monitor so that we can start targeting those chronically ill patients of ours. So we're working with different vendors to integrate into our EMRs so that all that reporting system and alert system can be integrated, can be streamlined for a better patient experience. And the goal is better quality of life for those really sick children. And bringing it all together is what we have. It used to be a pilot, and now it's a Nemours app. So we launched it November 3rd, 2017. And what it is, it's bringing all of these digital assets, including peripheral devices and wearables, to integrate into one source, one patient experience, whether that's the web or a mobile. But it's going to become a Nemours app. It's where patients or families can go and say, how am I feeling today? For instance, let's look at it from the asthma lens. For instance, my child is not feeling well. There's happy faces, small, sad faces. They'll click that. Based on their clicks and their input, it's going to trigger more actions. So did you have your inhaler today? Did you take it appropriately? Now, how are you feeling? Is this urgent enough? Let's connect you with an urgent care telemedicine provider, or let's connect you with your pediatrician or specialist in that instance. Keeping track of all the appointments, all the medication, all the educational material, all that incorporated into one app, so that just making it a seamless experience for the parent and child to manage their health per se. So I have a short video, I believe it's 3 minutes long, but it's very engaging. And this would give you a really good idea about what the Nemours app is. And I'll go ahead and start it.
Meet Regina and Brianna. Regina is a single mother of 8-year-old Brianna. After some recent bouts of coughing and wheezing, Brianna's pediatrician made a preliminary diagnosis of asthma. He recommended an appointment with a pulmonologist. Dr. Granger confirms the diagnosis of asthma. That's a scary moment for both Regina and Brianna. Dr. Granger explains what asthma is and how Brianna's asthma can be managed so she can live an active life. She creates an asthma action plan in Epic, prescribes controller and quick relief medications, devices that will help monitor Brianna's asthma from home, and a peak flow meter. Dr. Granger also encourages them to keep an asthma journal to bring to their next visit. It's a lot to keep track of, and Regina is feeling overwhelmed. Dr. Granger recommends Regina use the Nemours app to help manage it all. Quick, easy to understand, and accessible by any device, the app is a simple answer for a busy single mom. The asthma experience is built on top of My Nemours, leveraging the security and operational rules already established and adding new functionality. From the dashboard, Regina can log an entry in Brianna's asthma journal to indicate how she's feeling. She is able to note details, like how Brianna's exercise and sleep have been affected, the symptoms Brianna has experienced, and saves her entry. Regina is unsure if Brianna needs immediate care for her symptoms. Regina checks their asthma action plan set up by Dr. Granger. It takes just a few taps to answer some quick questions. She sees that Brianna is in the yellow zone. Regina gives Brianna a dose of her quick relief medication as prescribed. Brianna is still experiencing symptoms after taking the medicine. Did she inhale it correctly? To make sure, Regina views the Kids Health how-to video for using a meter dose pump inhaler with spacer. Regina feels better knowing that Brianna has taken her medicine properly. but is still worried that Brianna doesn't feel better yet. So she decides to try the online doctor visit feature. This telehealth capability is built right into the new digital experience. Regina selects Dr. Vyas.
Hi, Regina and Brianna. I'm Dr. Vyas with Nemours Care Connect.
It's nice to meet you. Thank you.
Yeah, absolutely. What's going on?
Well, Brianna has been wheezing and she has a temperature of about 100.
Okay.
We did give her medicine about 10 minutes ago.
And I know that you have a connected stethoscope with you.
I do, yes.
You can put it up to her right lung. All right. So she is wheezing. So what we're going to do is I'm going to go ahead and prescribe her some oral steroids. It's going to be a suspension, so it's going to be just a little bit of liquid. I'm going to write all this up so that you guys can see today's summary. I'm also going to send it to your pediatrician and your pulmonologist.
Thank you so much, Dr. Vyas. I feel so much better.
On the day of her follow-up appointment, she follows the map to the facility. She's warmly greeted with a welcome message when she gets on site. The welcome message has all her appointment particulars and a number to call if she has questions. She automatically transitions to the in-building wayfinding to get her right up to the registration desk. Information collected from the app is provided for the clinician via a dashboard, accessible from the patient record in Epic. This gives the Nemours clinician a window into how Brianna has been experiencing her condition in between visits. Dr. Livingston can see Brianna's journal entries and peak flow readings and notes there's nothing here to be worried about. Looks like Brianna's asthma is well controlled. All the tools she needs are right in the palm of her hand.
So what this highlights, I think, is how we're trying to integrate telemedicine into our everyday operations. It seems like telemedicine has been more of like its own entity, and what we're trying to do is normalize it within our systems, amongst our associates, physician groups, amongst our children. We're working on integration from the telemedicine platform to our EMRs, so that right now we're in phase 2 of integration, but the vision would be, for instance, whether a child is registered within the telemedicine platform or within our EMR, there's a bidirectional interface that populates both information, so demographics, billing information, and also syncing, for instance, the doctor, so the progress notes and whatnot. So, and technically we're trying to normalize it so that it becomes just one of our ways of providing healthcare versus, would you prefer a telemedicine visit or an in-person visit? It just becomes so normal that one time you can see a physician via this method and another time, just like going to an urgent care versus a PCP office versus this. It's just another means of communication. That said, again, Nemours anytime, anywhere, and this is our way of empowering families to manage their health care. So that said, I'm going to open it up to question and back to Lloyd.
Thank you so much, Natalina. Of course, as we mentioned early on in the presentation with the introductions, if you have questions, you're free to use the chat function, which can be found at the bottom of your screen in the Zoom window. And that would give you the opportunity to ask any questions that you may have of Natalina at this time. I see no questions now, but I'm going to give it another few seconds to see if we do have any before we move on. Any questions, ask now. Natalina, you can go ahead if you want to and advance the slide, and I'll just kind of monitor that over the next few seconds and see our next webinar topic. We don't have the topic, don't have that information, but it will be Thursday, February the 15th, and you will receive more information about that. So we do have one question that come in, Natalina, and it says, this is from Allison Neff, and Allison is asking, what telehealth vendor are you using? Okay, we're using the American Well platform at this point. We do also have video, VIDYO, that we use for
for instance, provider to provider, using that with our health systems, with our cruise lines. Video is more tailored to where there's no patient experience involved. And then American Well has that full-on patient experience.
Okay. All right. We have actually two other questions. Noah Pollak says, hello, I'm a private practice pediatrician in New Jersey.
Okay.
Can I refer my patients to your urgent care telehealth service after hours?
Yes, we are in New Jersey. We're actually in 6 states. So Florida, Georgia, Maryland, New Jersey, Delaware, and Pennsylvania. And we operate 24/7. So yes, you may. Happy to share my information and provide you with further information shall you choose that route.
Okay. Ted Bartison asks, can you expand on practical ways to get traction without the encounter being reimbursed? Focused on FQHC location. So I'm guessing from an FQHC perspective, maybe a little bit different. But if you don't mind, expand on practical ways to get traction without the encounter being reimbursed.
So we are working with FQHCs from a perspective, and let me take the school-based angle. So for instance, for schools that don't have funding to support for maybe the equipment or funding to support the visits, working through the FQHC allows us in a way to work together to provide such equipment. However, we cannot provide free healthcare per se as a healthcare entity. It's illegal. What we do, we can only capitalize on those maybe post-op visits, discharge visits, things like that we can incorporate into a global bill or a global charge per se. But we cannot, if it's no reimbursement, unless if it's a grant or a donation, we cannot provide free healthcare, if that makes sense. I hope I answered your question.
All right. One asks, do you do anything in Puerto Rico or the U.S. Virgin Islands? If not, have you considered working in those jurisdictions?
So during Hurricane Irma, we have provided free health services, and that negates what I just said, but I'll explain. To the Virgin Islands and to Puerto Rico, that was as a result as when the states announce like a state of emergency and ask for healthcare volunteers, we then can start providing free health. So in that instance, over a period of, I think it was September 8th all the way through the 16th, we provided free healthcare, and on to Maria. When Maria came, we started providing free healthcare in the Virgin Islands and Puerto Rico. We did it in 2 ways. One was communication blasts via social media, emails, especially to the families of those families, because then it was, you know, some of their TVs were out, electricity was out and stuff. So being able to provide, send that message across somehow. Another thing we did was shipped carts, iPads, and telemedicine carts down there, so that, and we put them in resource centers where the word was spread that this is free healthcare, access to free healthcare, where children and families would come there, and we would provide telemedicine services. Also within the states here in Florida, after Maria specifically, we did put carts in, or during Maria and after, in shelters, like at the airport, where when people were coming in, they were being checked in, and if they needed any medical help, for instance, prescriptions that they've lost with the storm or stuff, we were able to provide access to care that way. But that was our only encounter per se, was through a hurricane. I know that we continue to talk to governments, and I know that assistance was wanted on a longer, because the damage was so big, they wanted partnerships for like 5 years, 10 years out. So I know we continue to talk, but there hasn't been any traction per se that I can report out other than that.
All right. So next question, how has it been entering the data? This is Ted Bartison. Entering data from the telehealth visit into the EMR. And I think you pretty much covered that with the all-in-one platform that you guys have. So, right?
Well, right now we have, like, we're in phase 2 of the integration. Phase 1 was demographics. Phase 2, we're trying to do billing. Ideally, eventually it would be like a one and all integrated system. However, right now we use the technology to connect with the patient. So initial intake of information, demographics, and chief complaints and insurance information for real-time eligibility check and payments. But beyond that, our doctors do document into our electronic medical record from there. So we don't document right now into the telemedicine platform. With the next phase of integration, we're hoping that would loop in.
So these are your physicians, just so I'm correct, these are your physicians and they have access to your EMR. I know in other telemedicine ventures, such as telestroke and things of that nature, where documentation is, dictating and things of that nature, those neurologists are typically given access into those EMRs. But your physicians are just entering into your EMR. You're not necessarily accessing physicians outside of your network, correct?
Correct to an extent. So because our telemedicine program incorporates our own physicians, and Nemours employs physician across the board. So we're talking specialty or non-specialty. We employ our own physicians. However, we do populate other telemedicine vendor exchanges, what we call. So for instance, our providers do populate an exchange where they're seeing someone else's patients. And in that instance, we do not document into our EMR because, the patient is not ours. It's kind of like a leasing agreement where we lease our providers to provide services to other entities. And in that instance, they'll document depending on that agreement, whether it's going to be in a telemedicine platform or if they want them to document and give them access to the EMR, they'll do so.
All right, so next question. Are most types of specialists involved in this telehealth effort? How can someone determine if the specialist they need utilizes telehealth or not?
So the specialty referral and onboarding is the same whether it's via telemedicine or not. So technically a patient would still be referred to us, whether it's from a Nemours PCP or a non-Nemours PCP from a specialty perspective. And they would go through the regular process, which generally it's calling for an appointment. We'll gather their medical history from whether it's a hospital, a PCP or whatnot. And then it's based on that use case. Is it applicable to a telemedicine? Is this case, can it be seen via telemedicine or not? And then it goes from there. Even if it cannot be seen initially via telemedicine, we might need an initial, for instance, physical exam or a face-to-face. Beyond that, our specialists can do follow-up visits or in between your regular visits. For instance, they'll do every other visit as a telemedicine visit. But we try to streamline it so that telemedicine is only just a different way of delivery and not its own entity. And it's built into the physician's schedule per se. So for instance, our endocrinologist would have his schedule template, and based on that case, they can schedule an in-person, or he can still be sitting in his same office and connecting with a patient across the state. So it's case by case dependent.
All right. So beyond using TytoCare devices, are you using any other technologies for home monitoring? And that's Doug Rowe.
Beyond TytoCare, what are we using? I do not have that information, to be honest. I would have to get you that information if it can be disclosed at this point. But let me, if I can, Lloyd, maybe take his name or contact information and get back with him.
Okay. Is it possible to integrate this telemedicine with any other EMR? I guess if a clinician wanted to get this application for his specialty, is it customizable? So I'm guessing he's talking about your platform.
So our platform, we're using, it's a vendor, we're using a vendor, American Well. However, if you're talking about maybe connecting specifically with Nemours, so for instance, if you are a PCP or a specialist that wants to bring in another specialty or maybe after our services or behavioral or something, yes, we can integrate. It's not integration per se, I guess. We can connect and partner so that we can become, we can provide services at your location per se. However, from a Nemours perspective, we partner. However, if you want to provide services under the name of Nemours, then you're going to have to become a Nemours employed physician per se. Okay. So we do partner with other non-Nemours physicians. However, if the care is provided by Nemours, it's still a Nemours care under the Nemours title.
With the Puerto Rico use case, we're back to the Puerto Rico thing. How did you document care and send it forward with the patient and our providers who were remote?
So via telemedicine, it's all virtual. So the documentation was the same. As long as we can see and hear the patient, we're using the platform to see and hear the patient, and then we document into our own medical record number, medical record system. And an after visit summary would be provided to every patient, regardless whether Puerto Rico or not. And then if we have access to that physician's information, mainly fax number or email, we can do so because it's triggered straight from our EMR, electronic medical record.
Okay. Are APRNs conducting visits? What about dietitians, speech language, hearing pathologists?
So we do have nutrition dietitians. APRNs are not. And it depends on the specialty, right? So for our 24/7 on-demand urgent care, it's strictly physicians, MDs. However, different specialties might, if they choose to engage, then as long as they have from regulation, the licensing necessary to see the patients, then absolutely we encourage them to do so.
Okay. And then last question that I have here currently, and this goes back to TytoCare. Does the TytoCare device, is it integrating into your EMR from a data standpoint? Or is it using its own platform?
Yes, we are integrating it. We actually have integrated it straight into Epic, which is our EMR. And also we have been pushing our telemedicine vendor, which is Amwell, to integrate it as well. That way, as I mentioned before, we operate independently as Nemours, and then we operate, sometimes we see patients as Nemours physicians, but for another health system. So that way, if we're documenting into, for instance, Amwell, we can have that integration and also have that integration for our own children as well. So yes, we are, it has its own, TytoCare has its own platform. However, we are integrating it into our EMR and into our telehealth platform.
Okay. All right. And last, do you do any Zika-related consultations?
Not via telemedicine to date that I can speak of. However, yes, we do have an infectious disease, actually a whole department on board that is heavily engaged with Zika and other diseases. So if I can provide you with further detail and information on that department if you'd like, so I can take a name. Sorry, Lloyd, I only see my screen right now, so I'm not seeing who's sending me any questions.
No, that's fine. And anyone that needs further information, you could reach out to me. My contact information can be found at www.setrc.us. And that's just short for Southeastern Telehealth Resource Center. So And then I can get any information or pass Natalina's information on to you as well. So Natalina, if you'll advance the slide, don't forget Thursday, February the 15th will be our next webinar. Of course, your opinion matters to us. You can participate in a brief survey here using SurveyMonkey, can be found if you don't mind, and that will help us out as we move forward as the consortium of telehealth resource centers doing these webinars. We want to make sure that we're providing valuable and useful information to you all. So having said that, we would like to thank you for attending and participating. Once again, if you go out to the Telehealth Resource Center's YouTube channel, you can find this presentation along with all other presentations as well. Thank you very much for attending.
Thank you.